For joining the August BHAG meeting. Let us see here. I'm going to go ahead and get started with our meeting agenda. So we're just going to welcome with some introductions to begin with. Margaret Fowler is going to be giving us a presentation on the Prince George's County Emergency Crisis Continuum. We'll get to see how this connects to the goals and objectives of the group and see next steps for organizations to be able to plug into that continuum. We'll do so by having that open discussion time about those specific continuum access points. We will, of course, open the floor for community announcements, go over some upcoming meetings, and then we will adjourn for the day. Does that sound all right with folks? Great. Let us move forward. So to start off, we just want to open the floor for some introductions to see who we have on the call today. So if folks would like to unmute, or you can put in the chat, if you could put your name, organization, and a favorite activity you did over the summer. And I can go ahead and go first. My name is Taylor Palmer. I am with the Prince George's County Health Department. And my favorite activity I did this summer, I saw Taylor Swift front row in Pittsburgh, and it was a magical experience.
I'll go next. My name is Margaret Fowler, and I work for TLC. And the favorite activity I did this summer is I went to Mackinac Island in Michigan. It was absolutely beautiful.
That caters specifically to you.
Taylor, I have to echo you. Courtney Reed, Prince George's Health Department, Methadone Clinic. My favorite activity was Beyonce concert.
I hope you weren't a part of that rain night.
I wasn't.
Good.
Good afternoon, everyone. Oh, go ahead.
So I was going to say, I will follow that. I was there on the rain night and it was a disaster. So I'm Andrea Butler from Aetna Better Health of Maryland. I'm the behavioral health liaison. I've been with this group the last several months. I will actually be leaving Aetna Better Health. So you guys may have someone else from our agency at some point join you. So I'm not going to pick Beyonce because that was, while fun, it was a lot going on that night. I'm going to say my grandmother turned 90 this month, and we had a huge celebration for her, give people their flowers while they're still alive. And this is the one thing she's been talking about. So that's exciting.
Good afternoon, everyone. Denise Dunbar here. I think, who was that? Someone who just spoke. I was at the August 8th Beyonce concert, and it was all worth it. She put a show on, and it was worth it. But I think my favorite activity that I did this summer was that I attended my son's white coat ceremony for his entrance into med school. So that has to top the Beyonce concert.
Mm-hmm. Congratulations.
Thank you. All righty.
My name is Kajane Bobo. I am a doctoral student with Old Dominion University. My favorite thing this summer is hard to pin down. I will say the Beyonce concert on the Not Rain Day was very fun. She does put on a great show. My favorite activity had to be volunteering at our church for Vacation Bible Study doing the snow cone machine. I learned how to make snow cones, and that was exciting for me.
Make sure you add that to your resume. I'm Kim. I'm Kim Stinchcomb. I'm the manager of the Healthcare Action Coalition with the Health Department. And my favorite activity, I was really bummed that I was not able to go to any of those concerts, but I spent a lot of my summer traveling. So I went to Portugal, and it was my first time out of the country for many, many years. So it was a really exciting trip.
Anyone else who would like to come off of mute? See, we've got some fun activities here in the chat. A lot of celebrations, some concerts, and some travel. Sounds like it has been a wonderful summer so far. All right. Well, we will go ahead and hop into, we're going to go over the emergency crisis continuum. But before I do that, I wanted just to set some context for our discussion today and just offer a reminder of this first goal and the associated objectives and strategies to ground our conversation today. So just as a reminder, we created this goal, this first goal, to promote the integration of behavioral health and somatic care among providers, community programs, and schools to address the emerging behavioral health problems, behavioral health needs in Prince George's County. And so again, we are really wanting to focus in on this first strategy here of the creation of a behavioral health continuum of care process. So that is what we will be focusing on for the next several meetings, seeing how we can get some partners involved and what this continuum of care could look like in Prince George's County to be able to identify providers and referral programs, but then to also be able to identify gaps and the needed resources to then get that out to important audiences to be able to promote change. So with all of that being said, just wanted to have this up for folks to have a reminder of what we'll be working towards in these future working meetings. And with that, I'm going to invite Margaret to go ahead and share her screen to give us a little bit of a presentation on the emergency crisis continuum to see where some organizations can plug in, if that's okay.
Okay. Thank you, Taylor. And I do just want to mention that Carlos Makel is a colleague of mine that we are co-chairing this together. So he will also be presenting some of the, let me see. Let's see. Well, I didn't get a chance to, let me see. Want to share, didn't tell me, there we go, my screen. Okay. So Carlos will be also doing some of this presentation towards the end. Can you all see my screen?
If you start that one, perfect. Yes, we can see it now.
Okay. Okay. Well, first of all, I'd like to thank Taylor for allowing me to share the crisis continuum that we're building for Prince George's County. And it is part of the TLC-MD grant funding that we received from the HSCRC as part of the Behavioral Health Catalyst grant. And I wanted to share with you guys today sort of the pieces that have already been built, and then share with you the pieces that we really need your help on. Like Taylor said, really integrating this into how do we get the whole community involved. So this next slide here shows basically the emergency crisis continuum that is currently being built. So we have a 911 988 diversion project and pilot that we're working on, and we just finished actually, and I'll share some of the information about that. We have the development of this mobile crisis team. The TLC funds 4 of the 6 mobile response teams that are currently in the county. And then we're also building the Dyer Care Center, which is going to be the first of its kind in the state of Maryland. It's going to be a crisis stabilization center based upon the Crisis Now model, and it will be available 24/7. And then you'll see this piece right here. This is the piece that we're going to talk about today also, and how does this group fit in to helping to continue to build the crisis continuum beyond the emergency pieces. And as you can see, TLC actually is part of the 6 hospital systems in Prince George's County, and the hospitals that are partnering with us on this particular grant is Adventist Healthcare Fort Washington, University of Maryland Capital Region, and MedStar Southern Maryland. So what I'd like to have you guys think about before we get into all the components of this crisis continuum in more detail is those additional resources. This is how I would like you guys to figure you can fit into helping build this continuum beyond the emergency crisis components. I'd like to think about us as a wheel, and each one of us being those spokes that help support that wheel in our community. So please, as I'm going along with the different components, thinking about how you can join in and become owners of this crisis continuum, and where do you fit in? The next slide here is these are the components that we have already begun to build as part of that emergency crisis continuum. We have the call center and air traffic control software, a 24-hour mobile response team, transportation to get people from crisis to a facility. And then we're also looking at readmission reductions program and a 30-day outpatient intensive treatment program. And then we're talking about the receiving and stabilization center. And over the next few slides, we'll go in this order, give a little bit more detail about each one of these. The call center module, or what we're calling the air traffic control software, it basically has 3 components, but in Prince George's County, we only purchased the mobile response module. So we have a call center module, which we're looking at now as we've gone through this now for 2 years. We're realizing that the call center module would help with the integration of data. And then these are for you guys to understand, and maybe again where you will be able to join the team in this continuum. We're also looking at purchasing a referral module, which will help. It's on the entrance side as well as exiting this emergency crisis continuum. How do we make sure that we're navigating residents to resources beyond the crisis continuum? As you can see here, the company we're using, and it's really being used at our level for the HSCRC Catalyst grant, as well as in Baltimore City, Baltimore County, Harford County, and Howard County. They're another HSCRC regional partnership, which they're using the BHL software as well. But what it allows us to do is have warm handoffs from the 988 to our mobile dispatch. It can give GPS locations for all of our mobile response teams as they're dispatched throughout the county. It gives us a date and time stamp of every call that comes in. And what has been very nice is that we can also know at what level each of the mobile response teams have responded to the call. They're en route to the call. They started an assessment. They've ended a assessment, and they may be in transport. So it allows the mobile response teams to be safe. It allows us to know where they are where they're at in their assessment, as well as if they're ending and ready to go to the next call if needed. We're also be able to download this data into a centralized data warehouse where we're actually tracking longitudinally the calls from the original call to the actual end of service that each individual resident who engages with us. The next item that we're looking at, or an item on the emergency crisis continuum, is a 911-988 diversion project. This was designed out of the police reform work group that happened in Prince George's County, and again is consistent with this Crisis Now best practices model. We have been working with the 911 call center since October of last year, and we have made great strides in doing those longitudinal look back of a call that started at 911, went to 988, and then went all the way through to a mobile response team. To date, we had 58 calls from October to December on the initial time first quarter, and then we were up to about 80 calls for them from January to June. The reason the numbers were so low is it was primarily the first party callers, but now and it was for just a short period of time. I'm happy to say that they're looking at expanding those hours and increasing the callers to secondary callers. So the pilot has ended and we're evaluating all that data, and hopefully we'll have a report soon that would be available for everybody here. The next component that we have is our mobile response teams. Like I said, we have 4, and then the county sponsors 2 additional teams. What we have done is we've created these rack cards that you see here. If any of you would like to have any of these, we'll be happy to get them out to you, but it helps educate the community about, instead of calling 911, we want to promote the 988 as the new behavioral health crisis number. And then we also have put the mobile response team's number on there, just so that they have both numbers and can make that call. But if they call 988, we're trying to have them again go through the Crisis Now best practices model, request MRT, and then they will be transferred. But it tells this community what is MRT, what do they do, what can they expect, and what are the benefits. And we're hoping that these RAC cards will help educate the community about calling 988 instead of 911. The next item that we have here, and we're calling them wraparound services, is our readmission reduction program. We know that in this, a lot of times we have residents that will have a repeat admission for behavioral health services. Mindula is part of the program where it is a referral source only from the hospital right now. But what it allows the hospitals to do is, if they have somebody who has repeated visits to their emergency room or have had inpatient stays, they can be referred to Mindula, which is a 30-day outpatient treatment program, and they will help them for 30 days until they can get, once they're stabilized, keep them stabilized and navigate them to, again, community-based resources. So here's another opportunity for members of this group to figure out how can we support, again, even from a 30-day outpatient intensive treatment program for somebody who has been having multiple visits to the hospital or the emergency room. The next item on our list is the Dyer Care Center and the Crisis Stabilization Center. And I'd like to turn this over to Carlos. He is an expert when it comes to the Crisis Stabilization Center, and he has opened many of these throughout the country, and he has joined TLC to help us open this one here in Prince George's County. Carlos, I'll turn it over to you.
Thanks, Margaret, and hello, everyone. So as you can see here, you'll see the Crisis Stabilization Center that we have in Clinton, Maryland. You can see the address there is at 9314 Piscataway Road. And what we have here is a 16-chair facility, which is a 23-hour observation for stabilization as well. No wrong door. It follows that Crisis Now model, which is the SAMHSA gold standard. Accepting all walk-ins, police drop-offs, which we all know police spend a lot of their time with behavioral health individuals in the hospitals, as the current law states that they can't just drop them off, they have to stay in the hospitals with them. So this is going to decrease that drop-off time to about 3 to 5 minutes each admission. Also, the facility will accept voluntary and involuntary individuals and have the capacity to stabilize and divert individuals from going to a higher level of care. This facility is staffed with registered nurses, MD psychiatrists, peer specialists or peer recovery coaches, milieu specialists, and master level clinicians. This is really a great facility that's going to be put in place in Prince George's County to really aid with the mental health, substance use, and behavioral health needs.
Carlos, I'm going to share, I'd like to share with everybody sort of the video of the actual Dyer Care Center of what it would look like, the visual depiction. Would you like to walk them through that?
Sure.
Okay, let me pull that up for you. Let me pull it, see.
So while she does that, what you're going to see is what it would look like for an ambulance or police in this case, dropping an individual off at the Dyer Care Center. And I'll kind of walk you through what would transpire during that time. So as you can see, the police officer will be, law enforcement will be traveling around to the back of the building. Really want to be mindful of HIPAA and keeping sure that we protect people's rights and privacy. They will pull up to their specific entrance that's designated just for them, where they'll be welcomed by our staff and walked into the facility by law enforcement. And as you can see here, they will be coming to the first part of the area, which is where they will be doing the intake. If you could pause here for a second, Margaret. In this particular section, it's really important that staff has an opportunity to assess the individuals. During that time, they'll get a update from law enforcement, basically identifying what the presenting issues are. Also, a nurse will conduct a quick medical assessment of the individual to make sure that they're medically stable enough to be in the facility. At the same time, if they're not, we will still accept the person, but may need to take them to a hospital for different types of medical concerns. Obviously, we wouldn't be able to take someone with a bullet wound, but they will also be doing skin assessments, checking for different types of rashes or other skin infectious diseases, in addition to bed bugs, as well as documenting any type of wounds and checking for contraband. The master level clinician will also have an opportunity to introduce the individual to what the facility entails. And then we will let the officer go. So the officer really shouldn't be in this area. This whole process shouldn't take no longer than 3 to 5 minutes. Okay, Margaret. Now what you'll see is once they come onto the unit, this is pause it again right here. Hopefully it don't take you back again. Yep, perfect. Yep, and as you can see here, this is what you will call the milieu. If you notice, it's purposely wide open like this. We want staff to be able to engage with individuals and also have an opportunity to see them and have the individuals feel as though they're being supported at all times. They do have individual rooms providing they're at the level that they can handle a room. Some individuals will be designated to the front room, which they will have areas for people to sleep into, recliner area spaces for individuals who, let's say, may have a history of trauma and don't feel comfortable being in a room that they're not comfortable or familiar with. Also, if there's individuals that need to be in the line of sight because they are hyper suicidal or have a history of putting objects in their mouths, or if they just selectively want to be in the company of other people, they don't have to have a room. But for those people who are stable enough to have a room, they will be assigned a room where they can have their privacy and have the ability to come in and out freely. On this unit, they'll have computers, they'll have TVs, they'll have books. Again, they'll have the staff that's going to be engaging with them, where they'll be able to experience group therapy sessions, one-to-one interventions, master level clinicians doing an assessment on them, and then ultimately seen by a psychiatrist who will determine their disposition, whether that's what we hope is connecting them to organic support or the outpatient provider where they have the ability to go home stabilized. But in the case that they need to be escalated to a higher level of care, that will also be determined at that time as well. But really, what you're seeing is the least restrictive and most inclusive environment for individual experiencing crisis. Okay, Margaret. Yep, and you can see the chairs in the front room. You can see the eating area as well. And the windows are really important. You want to make sure that sunlight is coming in, and they are tinted on the outside so that no one can see out, but the guests have the opportunity to see out where nobody can see in. All right. And once an individual, I think we're going out to, yep, you can keep going. Yep, and this is, you'll see an area. So once they're discharged, they can come out of this area where they will be either picked up by a family member or picked up by an outpatient provider or whatever their next discharge plan is. That's it.
Okay, thank you, Carlos. And then the next page here is just showing you a diagram of basically the layout of the Dyer Care Center. And then you can see over here on the far right that they do have basically a warming kitchen that they will be able to provide food for the guests there. So just wanted to show you so you'd have a full vision of what the Dyer Care Center is going to be. It is currently under construction and moving forward. And the goal is to hopefully have this finished by the second week in November. And then what I would like to just share is, pulling together as a community, we can build the best behavioral health system. It takes a whole team. I think working together, we can be stronger. And we've seen this in just building the emergency crisis continuum, the tremendous amount of communication, collaboration between 911, 988, the mobile response teams, the emergency rooms. We've been able to build this system. We're still tweaking it, and it's a journey and a process. But now I think as we're reaching out beyond that, we love for everybody else to become owners of this system and figuring out how do I add to this continuum and making it the best for Prince George's County. And I'd like to share with everyone that this Crisis Stabilization Center and this whole continuum is the Crisis Now Best Practices model and will be the first in the state of Maryland. So I would like to also ask each one of us to continue to let's climb to the top and make it the best we can be. And I just want to say thank you for your time and would love to hear how you all would love to join in what you can do to be part of this team. Thank you.
Thank you for that, Margaret. And if it's okay, if we could open up for just a few minutes of questions here. We had one question here in the chat from Jay. Jay writes, will the facility have the ability to hold people involuntarily?
We're actually working on that right now. That's one of the things we're working with the state right now. There has been no formal regs for this particular facility, but we have been meeting with, the BHA to make sure and COMAR regs and all that will be aligned to meet these best practices model. So that will be the goal, that they can accept involuntary, but unfortunately the regs have not been finalized yet. But it is the intent to have those regs include that. Were there any other questions?
Oh, yes. Hi, this is Larry F. from Shepherd Pratt. I was just wondering about the facility's ability to accommodate youth or adolescents, if that was in the planning. I know that's historically been kind of a gap in the county, so I just would love to hear comments on that.
Yeah, Larry, I think this facility is for 18 and over, but I can say that the county is definitely looking at trying to get a facility like that. But unfortunately, right now, they don't have a stabilization center for youth and adolescents. But I think, I don't know if there's somebody probably on here about the youth and adolescents that might be able to give a better sense of where that is for them. But this facility is for 18 and over. I didn't know, is there anyone else on the call that might be able to answer Larry a little more clearly about that?
This is Jay again. Not exactly to that point, but in the homeless service system, Sasha Bruce is operating a youth drop-in center at the I guess the other Dyer building, the location where the Bridge Center at Adams House is located in Suitland. They have a youth drop-in facility for homeless and at-risk youth. And I think that their definition of homelessness is pretty broad. So basically any young person that needed to access any kind of services would be able to go there. The actual Bridge Center at Adams House also provides a whole suite of services for transition age youth, 18 to 24. And so that might also serve the needs for some of those individuals.
John, do you know how long they can stay there?
It's just a day center, so it doesn't operate overnight. I imagine that they probably close, 5 or 6. Yeah.
Okay, thank you. Well, I would love to also just hear feedback, please, on how, it doesn't have to be in the open if it, not necessarily, but really thinking about, we're going to need all kinds of services. As you can see, it's 23 hours. It's, and, or the most we have is like 30 days. And then where do they go next? We want to create this continuum and care coordination, that the behavioral health, services will be beyond the crisis, and then we can help prevent them from entering the emergency pieces. So that's the other part that we're really trying to look at, is those additional resources in building the strongest support we can in Prince George's County. And then, as you can see, we're going to need a lot of staff for the Dyer Care Center. So, also, we can have PRN. Carlos, you may be able to speak to this, being running one, there's always a need in case somebody calls out. We try to get everybody, if they want to be part of that, as, like I said, as part-time PRN. We're really excited about having this service in the county and would love people to be engaged as much as possible. So I don't know if you had anything else to add, Carlos.
Yeah, definitely gonna be highly seeking master level licensed clinicians in addition to registered nurses and certified peer specialists. So we will have full-time positions in addition to, as Margaret mentioned, we really like to have a pool of PRN staff and some part-time as well. Definitely. So be on the lookout for that as well. Taking all support when it comes to that. And Margaret, there is 2 questions in the chat. I can kind of speak to. Kimberly asked, will it have is it open across the state to residents outside of Maryland? My answer to that is, if a person from out of state is traveling through Prince George's County and they get and they you see themselves in a crisis, they do have the ability to come in there. Obviously we wouldn't be looking to take transfers from other, referrals from other states. But in the event, just think of it as, the same way it would be with, 911 or law enforcement. If someone's in, or the hospital or the ambulance, if someone is in this area and they are in need of crisis care and they are not a Maryland resident, they are more than welcome to come to the Dyer Care Center. In regards to care coordination, most definitely, Margaret and I are currently working with one of our providers, Mondula, to actually implement a process to where individuals who are discharged can be supported with wraparound services for 30 days, after discharge. In addition to, I think this leans into what she was talking about with the spokes on the wheel, right? With really making the connection with all of you all and outpatient providers that you may know, making sure that there are an abundance of options for individuals who are being discharged, especially when you think about voluntary individuals, the more options we can give someone, the better. So having a listing of referral sources to say, hey, would this work for you? Would you like to give this a try? So definitely making sure that we connect them to services after discharge, in addition to doing a 72-hour follow-up phone call.
And I think in addition to what Carlos is saying is, when we look at, we're going to sort of talk about this crossover, into other programs. If we know you may be somebody who has been incarcerated and may need, instead of going to the emergency room, they can go to the Dyer Care Center, and then can we get them connected to, or maybe they're part of a reentry program or somewhere else that's happening in our community, we can, navigate them to the next level of care, get them right back on track, and then add additional services where one service ends, we can connect them to another service, so that a lot of times when they're in a program or service and it comes to an end, there's all of a sudden it's like a drop. We don't want that to happen. So we're going to be connecting these services and navigating along that spoke. Like, where do we navigate them to the next spoke or the next spoke so that they don't get just dropped off when a program ends? Because like as you're seeing now, the Dyer Care Center is supposedly 23 hours. Well, we'll keep them longer if they need to, but officially it's 23 hours. But before, we're not going to discharge them to the street. We need to do that warm handoff to a community program or a service or a provider. So that's where, again, those are those additional resources. That's where this whole group can come in. So these are programs and services that are filling a gap that once existed, and now it's helping to move them into the community and the resources that were already there. So they're not replacing anything, they're adding value to hopefully everyone's program. And then how do we connect so that we continue that care coordination and continuity? And I want to just throw this another analogy out, and it helps go back to putting together the behavioral health and then the somatic acute needs. We're, unfortunately, our world separates behavioral health services from medical services, right? But it's one person. So if we can conceptualize that, we have that wheel that I showed you that we're creating, that strong spokes around the behavioral health hub. We have the medical hub, and let's put it on a bike, right? So there's two wheels, but they're moving the one person along. And then we're going to be doing those connections as well. So I want us to really conceptualize how we're building this and what we're trying to do, centered around the resident who needs the services. So I think with us putting our heads together, making sure we're integrating and sharing and building this continuum, we can build a very strong behavioral health system. And we're working, I can tell you the other grant we have is working on the chronic disease side of it. So I think we have both of those systems being built very strong in Prince George's County, but it needs all of us. And so that's where I just wanted to share this information, and hopefully you can find how you can be one of those spokes and help build this system. I didn't see any additional questions in the chat. Didn't know if anybody else had any other questions.
Margaret, this is Denise. Have you gone to the LBHA provider meeting yet?
I was at, yes, and actually we presented this information, Denise, probably a few months ago. So what we're trying to do is figure out how do we sort of combine some, we want representatives from the providers. So they do know about this. We have not given them an update regarding the Dyer Care Center, because I think it was probably, I want to say in January, when we did not really have a target date of opening. So we may want to go back there and share that information.
Yeah, I would recommend that as well. And because I think the partnership that you mentioned just now that you need, right, is the provider network. So when persons who access the Dyer Care Center are being discharged, there's a place. So if they're already connected to a provider in the community, this is an opportunity for you to have, I don't know if it's a continuity of care policy or something that would clearly outline what the discharge looks like, what the provider engagement coming into the facility to start working on treatment planning and transitioning back to, their agency. What would that look like? I think we need to start some kind of document that talks about continuity of care post-discharge, and then engagement, educating the providers about what service you provide, like what you just did, but also what this process would look like, what they would look like coming in to engage their consumer. Because sometimes if it's someone who has been disconnected for a while, they may need to do an assessment or an updated assessment. So there's a lot of work need to be done in order to bring them back to the fold.
Yeah, I think that's a wonderful idea. And these are the kind of things that we want to make sure where those touch points and where and how. And that's what we're building, the workflows, the protocols, the processes for that. We have standardization. And so everybody gets the information. So like you said, that continuity just continues, because sometimes people, when they discharge, they still don't have it all together, but by transferring, you say, let me see, Denise, this is what I heard just happened. So it's okay. Let's go from there. So then they know that they're being moved, or taken care of at a different level. So thank you for that. I really appreciate it. And I know, Carlos, you guys in the other facilities, you start the discharge planning process almost when they're admitted. So maybe we could get RI involved. They're going to be the vendors who are running the center to see what kind of documentation they have and bringing it to the providers meeting. Maybe that would be a good next step. Would you think that would be okay, Denise?
Yeah, that would be a great next step.
Okay.
It's going to be a
you.
long-time partnership. It's not a one and done either. It's this continuous working with the providers for them to have their input in, because at the end of the day, they're the ones coming to the facility, right? And they're the ones maybe referring or have to pick up their consumers. So you want to make sure that they're fully educated on the processes that you establish. Sorry, I can't talk.
Oh, no. Well, and I think we want everyone here to know and that this is a resource. Instead of calling 911 or going to the emergency room, hey, go there. That's where you'll get the best help you can get for mental health and substance abuse crises. So it's educating everybody in this room that has the potential to have an educational opportunity with who they serve. So, you know, we can also provide you guys with, we've done like a 1-pager about the Dyer Care Center, Q&As. We could be happy to get that out to everyone, or maybe what we can do, Kim and Taylor, we can give the electronic versions. You can get that sent out to everybody. Would that be helpful? I think Gina, you had your hand up. You're on mute, Gina.
Sorry, I'm just having a grand old conversation. So I may have missed this, but in case I didn't, will the Crisis Stabilization Center have formal partnerships with a select number of county community resources that they will work directly with and transitioning these folks into whatever services they provide?
We're hoping to set up any of those kinds of relationships because, again, we want to add value, and it's really, if that's what we can do for continuity of care, certainly, you know, like we want to, like I said, we already have a contract, for instance, like with Mindula, because it's part of the grant. And that's like, but it can only be, for instance, we're trying to tweak it a little bit because right now that can only be at the hospital level. So we want to be able to move those referrals to the Dyer Care Center instead of just the hospitals. So we're willing to, let's as a community figure out how we can best build this, and seeing how, you know, we can navigate patients to programs that are already existing rather than creating anything new. We would love to do that.
Okay. That would make sense to me.
Yeah, no, we're not building any, you know, we just built the lanes for really the MRT so that we could take the stress off police, fire, EMS. And we built the Dyer Care Center to take the stress off the ED, but it wants to be integrated into the existing systems.
Well, my own personal opinion is that you'll have a greater impact if you enter in some formal relationships with certain a core group of providers, if you will, as opposed to just referring people out to resources that you know are in the community, because you really have no authority or weight in terms of what services they're providing and the quality of those services. So I'm sure the local behavioral health authority would be happy to help you all maybe identify some providers that can provide those support services those adults might need, and who might be quality service, since we do monitor quality.
Yeah, and Gina, we're working very closely with Amani and LBHA. So and so they're all part of our advisory group. So we will definitely set those kind of systems up. And that was part of that referral module that we were talking about, that it's a closed loop. So it's like we will refer to that provider or that service, and then, you know, it's not be like, did they ever make it? It really is like, you know, hey, yes, they're here, that type of thing. So we
Like
want to
a
make
warm
sure.
handoff. Yeah.
Right.
Great.
Exactly.
Okay.
Yeah.
Perfect.
Thank you, Gina.
Certainly.
Kim.
Thank you. I'm curious if there's specific guidance or best practice criteria that is available to first responders, or maybe it's a training for them to define whether the crisis center or a hospital is the appropriate next step in a crisis situation.
Carlos, do you want to take that one?
Yeah, so we actually meet with agencies and providers now. We've been meeting with them for almost a year now, consistently. And we have put together workflows. And, you know, most importantly, like Margaret talked about in reference to the continuum, the 988 piece, to the MRT piece. But as far as the law enforcement goes, it's always going to be ideal for the least restrictive, most inclusive, like we're talking about. So the whole goal is to visualize the dire care center as the emergency room for crisis services. So opposed to taking a person to the hospital, unless they have a medical condition, the right practice, the gold standard practice says to take them to the crisis stabilization center.
Thank you.
And I just wanted to share too that, we only have 16 chairs. So we've also looked at, there will be potentially at capacity, and then they will have to take them to the emergency room. So that's part of also the system that we want to create, as far as like what is available for the police officers, so they don't inadvertently come there and not be available, because we don't want that, because then they're just going to stop. They're like, look, I'm going to take them where I know they have to take them. So, we're setting up systems like that as well. And again, we're always open. It's a process and a journey. We've been meeting with law enforcement, EMS, fire. They're excited. They always say, when are you opening? When are you opening? And, working on the protocols with them. But even like with the walk-ins, I'm thinking about, how do we have this support group who may be in contact with people that may need those services, making sure, and Carlos, I don't know, this is something that we haven't done. How do we make sure if they walk up that they're seen, because you don't want them to walk in and we not have somebody. So, this has all of a sudden made me just start thinking about how do we handle the walk-ups. We were trying to think, and we do have a website that's going to be for the Dire Care Center, and I should have put that in there. I should have shown you what that looks like, but we were thinking about having like, how the emergency rooms used to say there's a 30-minute wait, where you could click on it. I don't know. We're trying to be creative, but if you guys can think of, how we might let individuals know if there's a chair or availability too, because unfortunately, just like any capacity issue, I'm sure we're going to reach it pretty quickly. And we already know we need to probably have another crisis stabilization center built in Prince George's County, but we want to make sure that we can successfully sustain this one first. But there's already, we've been talking to, like, Carlos had a conversation with Senator Augustine. He wants something in the central part of Prince George's County, which we know that, we need to have that as well. So, let's just keep thinking about it together. Let's continue to talk about the needs. How do we interface? So I appreciate all this feedback. And, this is the kind of conversation that I really appreciate, and makes us strong together.
Thank you for your presentation, Margaret, and we will be sure to send out the slides and all of this relevant information so folks can review. Courtney, did you want to add something?
Yes, just one quick question. How do you, I guess, utilize doctors' community behavioral health urgent care for the non-acute cases, so that we can pretty much reserve those more acute cases for the crisis center?
So Courtney, I think what usually happens is between the 988 and then the mobile response teams, I would think that's where they, we definitely refer to urgent care and outpatient facilities, so they don't have to go to the Dire Care Center. So we're working with both of those entities to make sure they connect them if they're available, to those kind of services already.
Okay, thank you.
Mm-hmm.
And this will certainly be a part of a growing conversation, but just something for folks to think about with all of this information, and feel free to review after the meeting, and just to see where can your organization plug in, and how can we create this spokes and wheels model in PG County to best get folks connected to resources. I'm just going to reshare my screen here and just quickly move into some community announcements. So not a lot from the health department, just wanted to share this advancement on the policy side. So the FDA approved the second OTC naloxone spray for opioid overdose. So we attached the article link here if you would like to see a little bit more information about this new change, and we will be sure to send out these slides here. Any other community announcements from any partners on the call? Anything coming up? All right. Well, we want to invite everyone to save the date for the upcoming quarterly Prince George's County Healthcare Action Coalition meeting. This will be virtual, and this will be on September 12th, Tuesday, September 12th, from 6 to 7:30 p.m. We will send out information regarding that meeting. And our next BHAG work group meeting will be on Wednesday, September 20th, from 2 to 3 p.m. But we will be in contact beforehand with some materials for your review. And anything else before we adjourn for today? Right. Well, thank you all very much for your participation today. We will be sure to send out notes and the meeting recording if you would like to review it. But everyone have a wonderful rest of your week, and certainly reach out if there's anything you need before our next meeting.
Okay. Thank you.
Thank you, Margaret, and thank you, Carlos.
You're welcome.
Thank you both.
Thank you.
Taylor, you want me to just send you my slides?
Yes, that would be wonderful, and I can send those out. And any other resources